Uh, Good morning, sorry. I hope everyone can hear me. My topic is called Improving Feedback Through Transformation of Departmental Culture. But before I start the research project presentation, I'd like to show you a lovely picture of where I'm from. I'm from Boston. I'm a general internist at Brigham and Women's Hospital and one of the core faculty in the internal medicine residency program. I also teach a course at Harvard Medical School. And this topic fascinated me, and these are my advisors, Professor Van der Vleuten, Dr. Koenig, and Dr. Karen Mann from Canada, all of them experts in the field of qualitative research and the topic of assessment and feedback. So my overall research aim is to explore cultural and interpersonal factors that influence the exchange of feedback in clinical training settings. Now the question is, why am I interested in this subject? Because it leads to this problem. Everybody accepts that performance-based feedback is critical for professional growth, and yet our trainees over and over again fault the quality and frequency of feedback. So the culture of the clinical environment appears to promote feedback that's based on assumptions rather than observation, unlike many other cultures based on work from authors such as Watling. And much of this work was done at Maastricht. The culture also leads to an avoidance of constructive feedback. And after all, without constructive feedback, who can improve? And there's a deficiency of actionable feedback. And again, this goes to Bowd's work, which is feedback doesn't really happen until the learner or the receiver has acted on it. But then, before I get started, we'll talk about the gap. So we don't know really what factors enable feedback seeking and receptivity, what factors impact organizational culture as it relates to feedback, and more than anything else, what promotes bidirectional feedback. So the study, just a first pass, it's in 3 phases, and you can look at it as what do people feel about feedback in my department, and then I'll extrapolate those findings to the rest of the medical education community. So this will be explored through focus groups of residents and focus groups and interviews of faculty teachers. The second phase is, what do they do? Do they actually do what they say they feel? And this will be done through direct observations and videotaping of formal feedback sessions, followed by debriefing and reflection. And finally, based on these findings, how do I improve the culture and take these lessons from the local to the global context to develop a feedback module that doesn't talk about the technique of feedback provision, but really focuses on socio-cultural factors. So study 1 has completed, and in that I explored residents' perceptions regarding value of feedback in their professional development. What are the facilitators and barriers to effective feedback from their perceptions of how it is provided to them, and finally their own suggestions for best practices for effective feedback. 4 focus groups were conducted. A total of 30 residents, mixed postgraduate year 1, 2, and 3 participated, evenly distributed. All discussions were recorded and transcribed, and the data were coded and thematic analysis was performed. So some interesting themes came up. Without even talking about culture, 5 themes emerged which all revolved around the institutional culture. The first theme was that the cultural norm lacked clear expectations and messages around feedback. Even though they said feedback was important, this really time and space was not set aside. The second theme was that the prevailing culture of niceness did not facilitate honest feedback. Then when they talked about niceness, they talked about all faculty being very nice and polite, and they felt there was a good learning environment but not good enough for feedback. The third theme was bidirectional feedback is just not part of the culture. The fourth was socio-cultural factors, and mainly that involving relationships between residents and faculty influence credibility of the feedback given and receptivity to the feedback. And finally, in their best practices, they said there is a real need to establish a culture of longitudinal and professional growth. So the most unexpected finding or tension, I can call it, is this aspect of politeness. This was not sought and entirely emerged from the data. And quotes such as, "Everybody's so nice, they don't want to hurt other people's feelings. Nobody wants to say anything that may be taken as constructive or negative." So we call this the whole politeness concept. And we came up with this, I think, correlation that politeness and feedback were like the ostrich's approach to danger. So faculty bury their heads in the sand of politeness, and they don't want to say anything mean. Eventually they say nothing meaningful. So this was a little theory that emerged from the first study. And based on that, we discussed that organizational feedback culture seems to be very central to the process and impact of feedback. And this impacts honest dialogue between teachers and learners, or feedback receivers and recipients, trusting relationships, credibility and receptivity, which then leads to impact on professional growth. And we also felt that trusting relationships and honesty may in fact eventually enhance bidirectional feedback. So the second study, which has just begun, is probing this further, the fact of department of culture. What factors related to our department of culture influence the exchange of meaningful feedback? Now we're including faculty as well, so the perceptions of residents and attending physicians. So this study, I completed 5 resident focus groups, and the fifth was done to ensure that data saturation was reached. In the schedule 2 faculty focus groups to explore their perspectives, but individual faculty interviews are also scheduled because we can't get the subspecialist faculty who also teach the residents a lot without individual interviews, one-on-one interviews. And we've just taken a brief content analysis of the resident discussions. We've just begun that. So once this study is completed, the third 3A begins, which is actually looking at the behavior. We've now explored the feelings and perceptions, but then what are they actually doing? What verbal and non-verbal behaviors are used by attending physicians and residents during formal feedback sessions? While knowing that we won't be capturing informal feedback sessions, this is the best way to do some direct observations of feedback. This will be followed by facilitated reflection and reflexivity, and to explore whether this sort of facilitation can enhance awareness of effective and ineffective behaviors and promote behavior change. And finally, we hope to gather all the findings from study 1, 2, 3A, and 3B, and then design an intervention that really would address the socio-cultural aspects of feedback, such as relationships, such as direct observations, such as feedback-seeking behavior, and will all this improve the quality of feedback, particularly focusing on actionable feedback and bidirectional feedback, which is almost non-existent in our environment at this point. So that concludes my presentation, and I'm open for questions and suggestions.